Good evening, and welcome to the AUA's Global Perspectives in Urothelial Carcinoma Latin America Focus webinar. This webinar is presented by the AUA in partnership with SBU and CAL. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. The AUA is accredited by the ACCME and designates this Internet live activity for a maximum of 1.5 AMA PRA Category 1 credits. Course handouts from the presentations have been made available to you. Please visit AUA University to access the handouts. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the webinar. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format of this program. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit the AUA University to view Faculty and Education Council disclosures. The AUA would like to thank Astellas and Pfizer Incorporated for providing an independent educational grant in support of this webinar. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. Please note that course participants are prohibited from using or uploading content you accessed through this activity into external applications, bots, software, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models and generative AI. This live virtual event offers simultaneous translations in over 50 languages using innovative technology Wordly. Please scan the QR code on your screen and select your preferred language. Please note the AUA does not guarantee the accuracy of any translations performed by Wordly. I would like to extend a special thank you to our course directors and content creators, Dr. Broniman and Dr. Shariat, for their time, talent, and expertise in developing this program. Finally, I'd like to extend another special thank you to tonight's moderator, Dr. Juan Cipollini, and the rest of our regional faculty panel for their time, talent, and expertise tailoring tonight's program for our Latin America regional audience. At this time, I will now turn the webinar over to Dr. Cipollini.
Well, thank you once again, and good evening to Global Perspectives in Urothelial Carcinoma. It is a pleasure to be here tonight with you guys, sharing this wonderful discussion. Okay. So, based on the documented needs assessment, Global Perspective in Urothelial Carcinoma is an educational series focused on the latest advancements in urothelial carcinoma. This is a 90-minute live activity that will explore the evolving therapeutic options for patients with advanced urothelial carcinoma or metastatic urothelial carcinoma. We'll discuss the value of early identification and management of adverse events associated with UC. We'll also discuss with local experts on AUA and other local regional guidelines that translate into practice and the various roles of each provider within the multidisciplinary team as we treat these patients with advanced carcinoma. Some learning objectives at the conclusion of the activity. Like I mentioned, we'll discuss new and emerging treatment options for patients with advanced urothelial carcinoma. Some of this content today may not be familiar to many of our audience, but we hope that we could give you some new education on what's ahead in treating advanced urothelial carcinoma. We'll discuss some novel agents, mechanisms of action. We're also going to discuss some any differences in AUA or other national clinical guidelines. And then we'll touch briefly as well on managing these adverse events and other management strategies to reduce adverse events in patients on these very complex therapies. Now it's my pleasure to introduce you our experts tonight. I guess I should introduce myself first. My name is Juan Cipollini. I'm a urologic oncologist. I'm currently at the University of Arizona, and I have the pleasure of introducing our 4 panelists tonight. We're going to start with Dr. Regina Barragan Carrillo. She's an attending medical oncologist at the Mexican National Cancer Institute in Mexico City. We have Dr. Mario Fernandez. He's an associate professor of urology at the Clínica Alemana in Santiago de Chile. He's also the head of the CAO Bladder Cancer Working Group and a member of the IBCG Core Committee. We have Dr. Lucas Mendez Nogueira. He's a urologic oncologist, and he's a clinic research coordinator at the Federal University of Minas Gerais in Brazil. And last, we have Dr. Rodolfo Borges dos Reis. He's a professor and chief of urology at the University of Sao Paulo, also in Brazil. So welcome. Okay, so our first segment tonight is we're gonna start discussing some of these new and emerging treatment options. So the therapeutic landscape for advanced urothelial carcinoma has changed. In just a few years, we now have EV pembro as a first-line treatment for many patients, but this also creates new questions, not just about who should still get chemotherapy, but also what to do when those first-line treatment options fail. So we have a lot to unpack tonight, discussing the latest trial data and how we incorporate that into real life. And we're also going to touch bases on how molecular profiling fits into this decision-making that goes on for these patients. So let's start with in terms of staging. So increasingly, biology is influencing those early decisions. We have circulating tumor DNA status. We have molecular subtype, differentiating between luminar versus basal tumors. We have also commercially available next generation sequencing panels. And also we have new imaging modalities. So I will start with Dr. Fernandez. Are you currently using PET-CT or multiparametric MRI in Chile, and has that become important in making any decisions for your patients?
So hello, everybody. So thanks a lot for the invitation. It is an honor for me to be here with this excellent panel. Thanks, Dr. Cipollini. Well, if we go to, there are indeed very interesting new imaging tools available for bladder cancer. However, if you ask me if this is routine in Latin America right now, the short answer is no. Maybe mainly because of access, I would say. So right now the standard is still the CT, but of course, if PET-CT is available, it will add more information that we are used to with CT. And there are a couple of publications about that. There is indeed a higher sensitivity for nodal and distant mets if you compare it with the CT. There are a lot of trials going on, but we have seen so far that we can first be able to detect more metastasis with PET-CT, and second, we can also rule out some metastasis. So I think it is a great tool to add. So regarding MRI, I think it has, without a doubt, showed a very useful role in local staging. So we can maybe see if we're really dealing with a T1 versus T2, or if we're dealing with a T2 versus T3 or T4. However, its routine use is even under discussion, even if it is easily available. So it is not clear if we do a MRI in every patient before the TUR, it will really change something in our management. So right now the TUR is still the standard to have the staging in terms of T. And so I think MRI is still looking for its place. One additional problem in our setting in Latin America is that it is not widely available. So if you decide to do MRI, you will have to wait a couple of weeks, which we know that for bladder cancer could be relevant. So I would say that right now, if you have PET-CT, use it. For MRI, I think it is not still a standard. I think it has shown more usefulness as a tool in the follow-up of patients. For example, and then Regina can maybe comment on that, when we are, after a patient gets neoadjuvant chemotherapy or bladder sparing therapy, there are some publications that have shown that MRI may assess in a very good way if it's residual disease in the bladder. But I think in the initial management of a patient, there are very specific roles. For example, a tumor in a diverticula maybe will help us to assess it. But I think right now it is very debatable if it's a standard or not. And the last question that is there, I think PET-CT is clearly better than CT and bone scan as a standard. So again, if you have PET-CT, I think you should go on with the PET-CT.
Yeah, excellent points. A lot of these imaging modalities, even in America, they're available, but it doesn't mean it's going to be covered or reimbursed with insurance companies, and many times we have to arrange phone calls peer to peer. So even
Yes.
in a country with resources, it doesn't mean we have access to them. So uh,
I
so
think you skip one. Yes.
oh, sorry. So, I know we mentioned, molecular subtyping. I know that's probably a little bit more academic,
Yes.
the academic side, ctDNA, or circulating tumor DNA, really has, become a really hot topic in urology. Although the IMvigor011 study was negative for atezolizumab showing improved survival, it did show a role for circulating tumor DNA being beneficial for patients receiving atezolizumab. So, and also finding recurrence. I know we also have next generation sequencing panels. So molecular sequencing, I think, is also become a very increasingly used tool for patients to identify molecular targets. I guess my question is, in Chile or Mexico or Brazil, are you guys using any of these molecular tools in your initial treatment plans for your patients?
So in Chile, not right now. So of course, these are very nice tools, but we know that most of them are not even in the clinical guidelines so far. So they're very useful right now in clinical trials, especially ctDNA. But those are tools that we have right now in Chile. We don't have them available, and very specific places just for academic use in the context of a clinical trial. I would say that maybe the only one that would have some clinical utility right now is if you are looking for a second-line treatment in a metastatic patient, you will look after FGFR3 because of erdafitinib, which is an approved drug also here in Chile. But besides that, I think it's very promising, but sadly for in our setting, it is very difficult to get it.
Okay, and
I'm happy to piggyback a little bit on that discussion as from the medical oncologist kind of viewpoint. So in our setting, we have to be very realistic about the resource allocation and the resource availability we have. And for example, just going back a little bit into the past question, talking about imaging. So for example, with imaging, even though we might have, you know, a FDG pad available or so, we know that if we misuse that type of resource, we might delay the applicability for the patients who actually need it later on. So for example, I would use it exclusively in patients that I need, that it might change what I'm doing irrespectively. For example, if I have some findings on conventional imaging, like for example, CT and bone scan that are not completely clear, or if I'm seeing some alteration, for example, in retroperitoneal lymph nodes that might preclude the patient from receiving, you know, curative intent treatment instead of only systemic treatment. Those are the patients whom I allocate these resources. And under that same rationale, I would identify the patients that would require an NGS as only the group of patients who might be a candidate to receive a therapy later on. For example, if I'm seeing a patient with a very aggressive disease in the first-line treatment, that its performing status might preclude him from receiving like later lines of treatment, I might not be the one who might try to get the NGS instead of other group of patients that I'm seeing that might be responding well to therapy or are slowly progressing, that I have to take time into account, that I have 4 to 6 weeks until I obtain that result back and I can actually change what I'm doing currently.
Yeah, great points.
Yeah, I just want to make a comment too. It's related to, you know, the first question, is the PET-CT and the MRI or CT. It's just thinking that for the local staging, CT3, CT3, T4 or something else, like the PET doesn't work well to see the image. So if I have to classify by TNM, so PET is okay if I have some doubts with, you know, a match or even liver match that is more sensitive. But and of course that the other areas you guys pointed very well, the costs and availability and reimbursement and everything. But if you think about it, that's because you have this renal expression for FDG. So for local staging, for TNM, still CT and MRI are better than the PET-CT. And for molecular staging, I think it's the future, but the future in Latin America is not now. And so we have quite a few. We don't get a reimbursement for this. And what's happened here now, that some companies, pharma companies, they are providing the test. So and in an idea to have how many patients would be candidates for a future therapy and driven therapy by molecular tests. This is what's happening here, but it's not standard of care here for reimbursement, and even not the availability is still low.
All right, great discussion. Yeah, I don't use PET-CT for local staging. Mostly, you know, it is a big deal if before submitting somebody to cystectomy, right? You want to rule out stage 4 disease, which is a very important decision. MRI, I've only found it useful if I want to do a partial cystectomy, which is, you know, very rare, highly select cases, or you know, urachal tumors, you know, but I don't, you know, PET-CT is not my regular imaging modality. So moving on to yeah, this is an interesting topic, you know, in terms of cisplatin eligibility. So you know, for decades, you know, the first question when seeing a muscle invasive bladder cancer patient is whether they're going to be cisplatin eligible or not. You know, whether you're going to send them to the medical oncologist or you're going to do the cystectomy first. However, with EV pembro now available to both groups, regardless of cisplatin eligibility, I guess let me direct this question to Dr. Nogueira. Is that still a primary split, or how do you stratify those patients, especially in terms of frailty? Do you use any kind of frailty scoring when you refer them to medical oncology for chemotherapy, or when you sign them up for cystectomy, for surgery? What criteria? What are your thoughts on this?
So that's great. So thank you for having me here. Hi, everyone. So, Cipollina, I think the answer seems is no. I think is not the key. I think while the GANS criteria that includes factors like kidney function, performance status, and hair loss are still relevant, they're no longer the sole gatekeeper for the effective treatment. I think the landscape is shifting. So we are now moving toward a more personalized and nuanced approach, I believe, I think you can say. I think one of the main drivers for this change is the success of the combination therapies like the enfortumab vedotin with the pembrolizumab. So these treatments, as they have shown remarkable efficacy in patients who are both eligible and not eligible for cisplatin. So they change everything about this criteria, and this old paradigm effectively, I think, the blurring the lights for this old paradigm. So, and even more, for I think the recent trials like the Niagara trial, they're trying to challenge the Gauss criteria. So this the dichotomization of yes or no, or eligible or not to cisplatin. So the Niagara include patients with a lower renal function. So they kind of challenge this thing. So more patients can benefit from the platinum-based chemotherapy. So I think this is a significant step forward, and acknowledge that the previous criteria, the Gauss criteria, may have been overly restrictive, we may say. So, and I think with the clinical advances, there is a growing, I think, recognition of the importance of more holistic patient assessment. I think it's a very important thing. So frailty scores and comprehensive generic assessments are now being used to provide a more complete picture of the patient's overall health. I think, and I think it's helped us to make more treatment decisions, mainly for this elderly and frail patients. And these patients represent, I think, one of the most portion of the bladder cancer population that we see with the advanced disease. I think, of course, this ideal treatment plan is not always the one that can be implemented, like was just said about the image exams and everything. So there's a regional variations in drug availability and reimbursements that play a significant role in treatment decisions. So here in Brazil, most of patients there are accessed just for chemotherapy. So the Gauss criteria still remains important, not the sole decision point, but is a part of one of the main factors alongside the disease biology, patient preference, and overall health. I think that are considered is a shared decision-making process between the patient and the health team. So I believe that's still important, but it's not the whole thing that you have to use. And now more patients we're not used to be eligible for a good treatment are now are get this treatment because you have better treatment and less toxicities associated with them.
Yeah, and I know I jumped in right into EV pembro or enfortumab vedotin plus pembrolizumab. Do you guys have that available in Brazil or Mexico or Chile? Are you guys seeing patients being treated with those treatments?
Yep.
Yeah. Okay.
So in Chile, it's still not approved in Chile. There is a way to go. We don't have it yet.
Okay.
But in Brazil we have it, but it's not automatically. You have to fill some forms. And here we have like two systems, the public system and the private one. The private one, you can have it if you justify it. And the public, we don't have it. So they need to go to, the justice to get it.
I think for the public, you just have chemotherapy, isn't it, Rodolfo?
Yes, just chemo. One thing I just want to point that I really like your answer, Lucas, but we have to keep in mind that we treat patients with a disease. This is very important when I see a patient about the scores, the health scores and frailty. We're not treating a disease. We treat a patient who has a disease. So we need to look to the patient and see what we can do.
Exactly. So you have to be more, we need more personalized approach for those patients. So when we'll talk later about the guidelines, and I think just the shortcomings for the guidelines that you just say the disease, not the patient. So we need to change the way that you see the patient when you make decisions about the treatment that you're going to deliver.
So for Dr. Barragan, Are you using EV pembro for your patients? We know that when EV 302 came out in the New England Journal of Medicine a couple years ago, I know that was very exciting times. EV pembro kind of just doubled, right? Overall survival, progression-free survival over chemotherapy, and that was I know very well taken in the medical oncology community. Do you have that available in Mexico City? Are you prescribing it to your patients as the first line, or are you what's your algorithm?
So yeah, we do have it available in Mexico City, mostly in the private setting, no, not so much in the public setting, similar to my colleagues from the rest of Latin America. And it kind of depends also on the type of insurance coverage. But thinking from an academic standpoint, there are very few patients for whom I would not prescribe EVP as a first line of therapy. For example, if for some reason it would take me a lot of time for reimbursement, or if I'm seeing that a patient is presenting with a rapidly progressive or a very high burden disease that I need a very quick cytoreduction, then I would consider chemotherapy, in the sense that I don't want to be waiting for some reimbursement. I don't want to be waiting for someone on behind the desk to approve the therapy. And I love the comment that Dr. Nogueira mentioned, that we're not looking right now into patients as only as a GFR, or dichotomize them into platinum eligibility or not. I think it's good to have this kind of holistic viewpoint that we still have many, many patients in Latin America that at the end of the day, their only line of therapy, or at least at the beginning, it's going to be chemotherapy based. So I would not preclude them only on the matter of GFR. I think it's, for example, for the fellows and residents who are seeing this, there are a couple of good tools they can adapt to their own practice. For example, the G8, that might help them predict whether they would need a more comprehensive geriatric assessment or not, or the CART, that it's also a good tool to estimate previously how much chemotherapy toxicity a patient might have. But for us, at the end of the day, it's a little bit between access and which is realistic to have. But we do have, and it's a very nice combination that has very good clinical responses. Usually toxicity management tends to be on one part rash. So for example, if a patient has a history of very severe rash, then I might not find them as eligible as other group of patients, or very severe hyperglycemia, that Latin American population, diabetes is quite a problem. Those might be the patients for whom I wouldn't offer EVP in the first time and rather have chemotherapy.
And I meant to ask you also, could you explain us how enfortumab works for those of us that are just learning about this drug?
Yeah, absolutely. So it's one of this kind of novel group of drugs that's called an antibody drug conjugate. So it has two parts. One part's going to be binding to its target, that's called Nectin-4. So especially in bladder epithelium, Nectin-4 is overexpressed like in 90% of patients. So we do not need a biomarker to find whether patients are eligible or not, contrasting to, for example, the European approval for nivolumab, that one is based on a biomarker. And the payload is chemotherapy, the monomethyl aristatin A, that kind of works like a very potent type of docetaxel. So what it does is actually binds to the Nectin-4 target, and over there it releases its cytotoxic payload. And the rationale for us to combine it with pembrolizumab is that it kind of augment the potential immunogenicity within the tumor, and it changes the microenvironment, because now we have more kind of targets available systemically. So that's the rationale why it's better to use them in combination when it's feasible than use them in sequencing.
And then just a quick follow-up. What's your go-to second line, after patients fail first line therapy? I guess chemotherapy or EV pembro, what's your second line, or are you mostly just go by the genetic sequencing of the tumor?
That's an answer that probably if you ask 20 oncologists, everyone is going to give you a different answer. So after EVP, we don't know what to do. So mostly the evidence we have stems from retrospective, publications and revisions. Personally, I tend to use platinum-based chemotherapy. Retrospective evidence is pointing out an overall response rate of around 40 to 50%. So that's the rationale why I continue with chemotherapy. What in the best case scenario, whenever I have, for example, NGS, and I know whether there are any potential targets, for example, as previously mentioned by Dr. Fernandez, FGFR 2 or 3 fusions or mutations that might make them eligible for treatment with erdafitinib, or HER2 overexpression or mutations that might make them eligible for trastuzumab for HER2 directed therapy, then I might rather use them. But the main message here is whenever you face a patient like this, the best thing you can offer them, it's a clinical trial whenever it's available. So it's important for us in Latin America and in the rest of the world to advocate for us to open these type of trials, because at the end of the day, we might be able to offer treatment that outside the context of clinical trial, a patient might not be, able to access it. And asking about the double positive question, that's extremely rare. I have never encountered one, probably because of the quality of the evidence. I would favor FGFR3 inhibition instead of HER2, because one, it's a pan-tumor type of trial, and the other one, it's a bladder-specific trial for this specific target. But there is no correct answer, to be honest.
Yeah, that's a good question. I think here we just also will go with the erdafitinib, unless it's a very strongly positive HER2, H3 plus on IHC. So I know we gotta probably speed up a little bit. So we could, I guess, talk about immunotherapy really quick. So I know in America, in nivolumab, I know differences between the European model, where it's only for PD-L1 positive patients. Here, we just offer it to anyone that has adverse pathology after cystectomy. So my question, I guess, to the surgeons in the room, do you guys make that call? Are you guys are very active in sending these patients to get adjuvant immunotherapy? Or do you, again, use molecular testing, or do you leave that decision to the medical oncologist?
Basically, here, it depends if you can work in a multidisciplinary team. That I believe that most of us work here, because we are linked to university and big hospitals. So for us, it's easier because you have the board meetings, and we discuss clearly, and by the final we want, but the final word comes from the medical oncologist. Then they say this patient is fit or not fit, and okay, and I will run 2 or 4 cycles, so they decided. It's going to be up to them. We discuss, we take the case to the tumor board, but they decide when we do it. But I believe that in general practice, they don't refer patients. It's unusual. It's really unusual. I think that there is some publication that at least 80% of the patients, they don't get they should get neoadjuvant therapy, they don't get it in the real world set.
Yeah, and especially when it comes to this immunotherapy trials, we're seeing very high, very good complete response rates. And so, are you offering bladder preservation for patients that don't want to lose their bladder, or what is your criteria for offering, bladder sparing approach?
That's myself. Usually, I have a very serious conversation with the patient. Needs to be motivated, needs to be prepared for having the bladder removed like a salvage. Like 30-40% of the patients, they will have the bladder removed in 5 years, and it's a more challenging surgery, so you have more complications. And we know this, you have more reparations with infections and all this. But in basically select cases, no hydronephrosis, no multiple lesions, no CIS, good health status, and the compliance is very, very important. If the patient is not, able to come every 3 months and have a cystoscopy, so if they don't have cytology and everything, so by the end of the day, if you have hydronephrosis, if Cs or multiple lesions, I do not encourage this patient to have this. If they do it, they should know that 35% of you have the bladder removed in 5 years with more complications. That's it. But it's still an option. I believe that it is going to be the future, maybe because you have new drugs, and maybe the future is bright on bladder cancer, and maybe we are going to have good results over it.
I think, but I think on the other side, offering bladder preservation after complete clinical response, after neoadjuvant chemotherapy, for example, I think that's not a go right now. That's still immature. You can only do it within clinical trials. So the standard is still, if you use neoadjuvant chemotherapy and you have a maybe complete response in imaging, you still have to do the cystectomy. That's what you have to do. Another story, if the patient doesn't want to go on, well, that's another story. But I think you always should offer the cystectomy after neoadjuvant chemotherapy.
It's very important, Mario. I 100% agree with you because sometimes you don't see the cancer, but the cancer is there. When
Yes.
the specimens go to pathology, they say the cancer is there. The only thing that I believe that maybe is growing if is the CTC. If you treat the patient and you have no more CTCs, so maybe this is a trial. People are doing this, and we have to wait. But it's an interesting concept.
But I think this is a challenge that you're facing right now because the patients are returning without the disease and ergo. So if I don't have the disease, why should I have to undergo to a big surgery like a cystectomy? So I've heard this from 2 patients actually in the last 3 or 4 months. So I tried to convince them to have the cystectomy. One refused. So we're just following him. In the other one, we went to cystectomy, and there was tumor present on the specimen. So this is something that you have to face, and until you have a very good evidence response for that, we're going to be, I don't know, discussing with the patients, and it's a tough decision to make.
Yeah, and then we're gonna and then very quickly moving to a patient that has high volume disease or lymph node positive disease. Are you still, giving induction chemotherapy and offering surgery if they respond, or are you doing surgery regardless of imaging changes? What's y'all's criteria for doing more a little bit more heroic cystectomy? Like Dr. Zoshre, are you giving chemotherapy and offering surgery?
I think that standard of care is chemo followed by surgery for this kind of patients. This is the standard of care, and is the data is the only data that we have. So it's going and having chemo plus surgery, or now you have the IO data, but you don't have like survival data for these patients, and as patients on the trials, they are in one. But I believe that today's standard of care is preoperative chemotherapy plus surgery.
Okay. Well, that was a great, awesome, really great discussion for segment 1. So let's move on quickly to segment 2. I think it's a very nice topic, a little bit more holistic, because we know that treatment choices for patients with advanced urothelial carcinoma is getting more complex. We have, perioperative immunotherapy. We have anti-drug conjugates. We have bladder sparing approaches. We have ctDNA. So these, patients need the right expert at the right moment. So wanted to discuss, I think probably a very useful for very complex cases. For example, a multidisciplinary tumor board or multidisciplinary team. So, Dr. Fernandez, do you guys
Yes.
have a tumor board, a multidisciplinary team?
Yes.
And
Yes,
who
we
leads
have.
that? Who leads the team?
Well, obviously the urologist. No, I'm joking. So no, what we're reading here makes sense. So Medon leads the systemic part, we lead the surgical, and we have to have a consensus. But I think, the first doctor that a patient sees and is treated by is the urologist. So patients tend to do what we say to them because we were the first doctor that were involved with them. So I think we as urologists are the first one that must lead the patient to be discussed in the MDT, starting with that. So if we don't get the case to the MDT, it will not happen. So I think the urologist has a very important initial role in considering all of the multidisciplinary discussion, and after that, maybe the medonc will have a bigger, of course, a bigger role. But I think we are called to be the initial leaders here in pathway of the patient.
And so I know you have, besides you have the surgeon, you have the oncologist. What other specialty do you think is maybe underrepresented in this teams?
There's a very nice concept, the nurse navigator, the nurse navigator. The nurses that we have a nurse navigator in our MDT, which has a very important role to contact the patient, to coordinate with him all of the consults you have to have and everything. I think all of this medical specialties listed there are important, but I think the nurse here, the nurse navigator, has a very, very important role here, and I think this is probably the most underrated member.
I know we talked about trimodality therapy or bladder sparing therapy with radiation. So did you guys have your radiation oncologist as part of your tumor board
Yes.
and who makes that decision of
But
radiation?
again, I think the patient is dealing initially with us, and we have to be the ones to offer him TMT along with hysterectomy if it's the case, and also eventually to convince the patients to do TMT. And then we have to obviously discuss in the multidisciplinary team, but I think we have to trigger the TMT with the patient.
I absolutely agree. So I think we talked about this already. We talked about this immunotherapy. So I'm going to skip this. Actually, this is a great question. So after the cystectomy, you guys do the surgery. Who owns the survivorship? Who orders the follow-up scans? The labs. Do you guys keep them in your practice as surgeons, or do you guys pass them off to the medical oncologists? What do you guys do in your countries?
Yeah, I think that we have, it depends. If you are here at the university, so we have the TMT, and then we share all the season. We have a schedule, cystoscopy, the bladder is preserved. Usually they are followed by uro-oncology. And the medical oncology also play a role. They see all the complications, they see if they are responding well, and we follow it together. We call integration. But I do believe that in the private set, the vast majority of uro-oncology, they don't see the patients anymore. They do the surgery and they refer to medical oncologists, and the medical oncologists keep an eye on the patient, and that's it. If he has something that he believes that need to be done by surgeons, he refers back to the surgeon, like retinal stricture or something else, or bleeding or else. But so it depends on how large is your practice, who is practicing there.
Yeah. And so I know, do you guys probably we're here in America, because of the available resources, we do have high volume centers, but I've also seen local hospitals doing cystectomies, which I think is very impressive. But how do you guys do it in Brazil or Chile or Mexico? Do you guys refer those patients with advanced case, pathologies to, university centers or high volume centers? How do you guys do it back home?
So in
I
my
think
case,
it's
we do.
I'm sorry. Go ahead. Go ahead.
Oh, thank you, Dr. Norbera. So talking about Mexico, we tend to refer them to high volume centers because, we do have very robust data that shows that patients who are treated in these high volume centers do have the, lower perioperative mortality, better lymph node dissections, and better adherence to guideline-based treatment. And I want to be also highlighting the fact that it's not only about the treatment part, but also the survivorship, the follow-up requires probably in the best case scenario, a multidisciplinary team. So at least in my case, we're lucky enough to have an MDT that we're able to do it. But the complexity, and you guys are going to be the experts in this, of cystectomy is not something that I think should be done in a center that probably is doing 2, 3, 4 surgeries a year. But that's the Medon perspective.
I think in Brazil things are slowly changing because if you take the general urologists, they're not used to do cystectomies and they kind of insist and in TURPs and local resections, and then the patients, when are referred to a cystectomy, has more advanced disease. So this is changing. I think the general urologists they're not doing cystectomies, are trying to refer to specialized centers. But if you are in big centers, if you are in academic or institutional centers now, with the MDTs and everything, so, and even the local public system are starting referring to, to hospitals or institutions that have expertise in cystectomy. So this is a very important topic. This is it's a major surgery, and the team expertise is very linked to the outcome. So we need to grow this knowledge that is refer cystectomies and this at mainly the muscle invasive bladder cancer to institutions that have expertise in dealing with the patient, not only with the surgery, but the treatment, follow-up, and everything.
Absolutely agree.
Okay, awesome. Well, great discussion. So I think that's it for segment 2. So segment 3, I'm really looking forward to this segment, talking to the faculty from other parts of the world. So I'm very interested to see what the discussion leads. So we know guidelines are our compass, but in urothelial cancer, the landscape shifts very fast. We have the NCCN, we have the SEO AUA guidelines, we have ESMO European guidelines, we have ASCO. We also have national society guidelines, but every country has its different infrastructure, access, and so not every center is the same.
Well, I
So
think
mhm. Go
yes.
ahead.
So I think we urologists tend to look more at the European guidelines. I think medoncs looked more at the NCCN probably. And at the MDT, we usually discuss not based on only one guideline. We analyze the patient, and we analyze obviously what's available. And we also have right now our national guidelines. We developed it during the last year. So also we also have some local guidelines that can help us. But I think you don't have to be strict with one and keep on with one guideline. You have to see finally what's best for the patient and be flexible. So I think that there's not a winner if there is not an agreement between guidelines.
So you guys go by the EAU guidelines in Chile?
I would say urologists tend more
Huh.
to look at the EAU guidelines more than the UA. I think they're more easy to read. The recommendations are more easy to read. So I think it's more popular against the Chilean urologists to look at the EAU. But as I told you, we also have local guidelines right now. So that's also a big improvement for us.
What about Brazil? Which guidelines do you guys go by? The Americans or Europeans, or do you have your own society guidelines?
I believe that we check both, but I'm not quite sure what people follow more. We have ours too, and I think the guidelines are important, but the guideline doesn't have all answers. That's the problem. So it's still a lack of time between the evidence comes to be incorporated in guidelines. The second thing is today we are trying to personalize the treatment. So guidelines, they do not personalize the treatment. They give you rules and ideas that are very important. I'm not saying that the guidelines are not important. I believe that it shows you in a way that what can be done, what can't be done. But don't say for who. So you have to have the patience and think about the guidelines, the information there, the new information that are published. So you have to incorporate in your brain and take the decision, not only based on the information that's there.
That's a good point. I think that goes very nicely into the next question. I guess my question is for all four of you guys. Have you guys ever had to go against the guidelines because of maybe slow adoption? I know in my case, when EV302 came with EV pembro, 2 months later, I had a 46-year-old patient with plasmacytoid, N3, muscle invasive bladder cancer. And so actually we went outside the guidelines because he was in renal failure with nephrostomy tubes. And so I had to go a little bit ahead of the guidelines, or behind the, I don't know what I'm saying, outside the guidelines. But do you guys have any experience maybe going against guidelines, or because of slow adoption, or maybe poor reimbursement, poor access? Any examples in your respective practices?
Oh, I have, absolutely. I mean, I think the solution for that would be to incorporate a sort of like fast track section for some practice changing things. For example, as you mentioned with EVP, it took them a while to incorporate it to the NCC and guidelines, even though those tend to be the faster ones to incorporate novel changes. For example, ESMO might take longer. And if we look into the local guidelines, for example, the Mexican ones, Brazilian and Chilean ones, I think the major limitation is because it takes people a panel, a consensus voting. It's not as fast as it should be. So in those cases, if I have to be completely transparent, I have been going against the guidelines in the sense that I know there's better and more novel evidence that just hasn't been, written down within the guidelines. So I think if there's like a solution for it, would be some sort of fast track type of incorporation whenever we're seeing like a very important signal of activity, like for example, an increase in double of overall survival.
Okay.
So
Yeah.
I'm sorry.
No, go ahead.
But it's okay. So I think it's more and more are going to face the situation that I think the guidelines are made to I don't know, to provide a framework of evidence-based medicine. That's the point. And we have now the fast evolving field, not only in the urothelial cancer, but the prostate cancer, kidney cancer, and all the genitourinary cancer that we're dealing with. And there is there is a gap between the evidence base and the guidelines and the real world. That's evidence that you have. You have paper being published, and for that information be including a guidelines, it takes a long time. I think maybe it's why you answer a question about the European and AUA guidelines, because the European is updated more frequently than the AUA guidelines. So maybe you're looking for more, I don't know, updated information. But I think the main criticism they have the guidelines are they often based on the data from the high selected patient populations and not the real world that you have. So this is a very complicated, and you have to share with the patients that you have the data, you have strong data but this data is not on the guidelines, and the data that we have can be a good way to treat these patients and the best way based on the evidence that you have, but not in this is not in the guidelines because of their guidelines are not updated, or if the data that you have to that you build the guidelines do not incorporate the specific situation that patient have, like frail patients and patients that have borderline situations that are not included in clinical trials.
Yeah, I think that leads very well to really the next topic. And I know I mentioned, well, I haven't mentioned it. This is the first time I'm mentioning. I'm gonna try to say the name. I can't say it. Sacituzumab govitecan, or SG. I'm just gonna say SG. So, which was actually very enthusiastically approved back in 2021 for post-platinum, post-chemotherapy, metastatic urothelial carcinoma. And then, once the data mature and actually was found to not be beneficial, and the label was pulled from the U.S. markets in 2 3 years later. So I guess this question is probably better for Dr. Barragan, but what's your what do you have any experience prescribing SG? And have you learned it? Are you more cautious about any accelerated approvals of these new targeted therapies?
Yeah, so just to contextualize everyone, so the thing with SG is that it's this very classic example of an accelerated approval based on very compelling phase 2 data from the trophy U01 trial that was showing an overall response rate of like around 30%. Anyway, the confirmatory trial, which was the TROPiCS 04, did not meet its endpoint of overall survival, which led to the voluntary withdrawal in the US earlier this year. So that left us everyone with this difficult position that what to do with these patients that were still benefiting from the drug that was no longer available. So for me, the key lesson with all this was not to stop using accelerated approvals altogether, as they are like very useful and very essential to get patients promising drugs earlier on, but just to integrate them thoughtfully. So for example, talking about SG, one of the main caveats about the TROPiCS trial is that the use of filgrastim GCSF factor was not mandatory, even though in the clinic it had shown like an important rates of febrile neutropenia. So what I would invite everyone is just not say no, not to say no altogether to the accelerated approvals, just to be thoughtful on how to bring them to the patients, because at the end of the day, there's still a question lingering on the effectivity and mostly I would say on the toxicity profiles. So it was an important lesson, but altogether still useful to have this type of approval mechanisms.
Awesome. So actually, Dr. Nogueira, you mentioned this earlier, so what do you think recommendations fit the patients that we see? It sounded like you were maybe into some disagreement. What are your thoughts on
I think you need to improve a little bit the way that the guidelines are made. I think the best that the guidelines are made. So as I said before, I think the guidelines are based on the evidence-based medicine, clinical trials, and the patients that are recruited and are part of these clinical trials do not represent the real population that we face in our job. So we need different data. I don't know if you're saying about the post-pembro, post-EV pembro gap that we have. So maybe real-world registries and their programmatic trials and even assessment of the biology of the disease will change the way, because you need to personalize. And in my point of view, the guidelines are not personalized stuff, so they're just rigid, and they only see the disease, and it's rarely see the patient. So you have gaps that you say, so frailty and geriatric assessment integration is not, you're not used to see this in the guidelines. I've talked about this post-EV pembro. You have no, as Regina said, you have no evidence-based treatments available. You have to go to the other source to guide. And I believe this other specialties are represented in this the spinals for the guidelines, like the radiation oncologists, geriatricians, and clinicians that should, and even patients advocates that should be part of this. So we need to learn, I believe, this. I think guidelines are very important to guide our practice, but now with the rapid change in treatments and involvements that you have, I think we need to rethink the way that the guidelines are prepared and made.
Another point we want to make especially in Latin America, we are all mixed. So our population, you have high heterogeneity, genetic heterogeneity. So we are not Caucasians, or we have just quite a few. So we are mixed. So basically, we don't know if the response or even the disease, if they're the same that you guys have in Europe. And so this is something that now it's all the pharma companies, they realize this is really important, and they are bringing in some, studies. This is really very important too. So we have many open studies here, clinical trials, you can enroll our patients and even compare these patients and get also ancestrality, heterogeneity, and check if the tumor is the same, and if we can really transform the data that you have from the classic clinical trials to our population here. This is very, very, very important. Because by the end of the day, as I said before, we treat patients with the disease, not just the disease.
I think
Absolutely.
I'm sorry, go ahead.
No, go ahead. Sorry.
No, so I think it's important that Rodolfo has mentioned that even with the more importance that we see in genetic and genomics, there are variability in the world with the genetic and genomics phenotypes and genotypes, and I think this data have to be collected locally. It's the ideal thing. So I think the genetic profile from the North America is different from Europe, that's different from South America and Asian, whatever, and other places. So maybe the same information that if the same trial is made in different areas, the results would be completely different.
This point of view, I believe that big data and machine learning will play a very important role.
Good, good, good. So now we're going to transition to a little bit more specific discussion on managing adverse events. So, so now, we mentioned the, effective systemic options. We have EV, pembro, we have combinations of ADCs and immunotherapy. We discussed FGFR inhibitors, so that means very complex toxicities landscape. So in 2025, managing adverse events isn't just about patient comfort, it's about keeping patients on treatment long enough for them to achieve maximum benefit or maximum survival, right? So let's discuss a little bit on how to detect these adverse events. This might be maybe better for Dr. Barragan, recognizing immune-related adverse events for these patients. Are we getting better at managing or recognizing these adverse events? Or to you personally, what's the most difficult IO adverse event that you had to diagnose?
So we're definitely getting better at recognizing these immune-related adverse events, not only from the medical oncology standpoint, but also, for example, the urologists, the surgical oncologists that are being more aware of these types of therapy. So I have had patients who are being referred because they're the ones who initially notice, for example, a pneumonitis, a thyroiditis, and so 100% we're getting better, and I'm very happy to say the MDTs are one of the key factors that are playing a role in this, because I think the different specialties are more aware of the types of therapy we're using. And talking about which might be the one that's a little harder to recognize, probably I would think was adrenal insufficiency, because it can present like very non-specifically, like for example, only fatigue and maybe some slight hypotension. If you're seeing a patient who might be female, younger, but more fit than other patients, these symptoms might not be, as noticeable as a patient presenting with pneumonitis with this very cough and dyspnea. So I think at the end of the day, the key message I want to mention is that everyone should have a very low threshold for these type of adverse events. Not only the medical oncologist, but the whole MDT should be, aware and asking about them. And when something's off, when something's not right, communicate with your care team. And also it's also useful whenever they start doing the workup, doing electrolytes and doing other, tests that they believe are appropriate.
Yeah. So in terms of, grading the severity of the adverse event, actually for me, it's like, what's a very important symptom you tell patients that they should let you know right away? Like what's something, is it diarrhea? Is it fever? What is it that you tell them, hey, make sure you call me if this happens?
So whenever I'm in clinic, I used to tell them this is very likely to happen. This might kill you. Just to be very clear on things that we would be expecting, like for example, hypothyroidism down the line. But for example, symptoms that I need them to report is cough, dyspnea, unusual fatigue, like fatigue that would not let them doing their self-care activities. Fever tends to be one, and also more than 3 bowel evacuations that look like diarrhea. I rather them call me or call the ER or consult with their local team for this. But it's very clear for me with these ones. And also I tend to explain the timeline, that it's something they would not expect to see in the first 2 to 3 weeks of treatment. That's something that tends to be after 6 to 8 weeks whenever they happen.
And so when do you start antibiotics? Like, do you wait for a little grade 1, grade 2, or do you wait till they have to be admitted into a hospital, like grade 3 or above? What do you? Mhm.
steroids or antibiotics?
Either.
So yeah, I tend to start them at the same time, because if we don't you be very prompt about treatment, we might have consequences that might not be, reversed back. For example, the thing with pneumonitis, patients might develop, fibrotic lung if we don't start the steroids earlier on. But also there, at the end of the day, to some degrees, immunosuppressed patients, not because of the immunotherapy, because they tend to be older patients. We don't know under which circumstances they're living. So for grade 3, I start them at the same time. I do the whole workup. And then after, we have the bronchoscopy and the CT scan, I have the results back. Then I support myself with both the ID team and our pneumology team to decide whether we're facing, community-acquired pneumonia or an immune-mediated pneumonitis.
Okay. And do you stop IO therapy completely, or will you restart it?
Depends on the severity. So for example, for grade 3 and beyond, I tend to stop them unless very specific case scenarios. For example, the patient is having an excellent response and I have very good communication with them. And if for some reason it would happen again, then they have very good access to medical care, I might have this conversation with them. For grade 3 skin reactions, I do restart, but for this, I tend to go very, very much by the guidelines. And here I would recommend the CITSI guidelines for the fellows who are watching this. They are actually very useful and very comprehensive on when to stop and when to restart again. For example, for other ones, myocarditis, even though it's for example, let's say not a grade 3, those are the ones that if they happen again, it might kill the patient, so I wouldn't restart.
Yeah. And now going back to EV and enfortumab. So I know that neuropathy, almost half the patients get neuropathy. So do you have a grade also where you would stop EV entirely, or what are your thoughts?
Yeah, because it's accumulative and it's dose limited, then I tend to stop after 6 to 8 cycles, depending on how the patient is feeling, because I don't want to get to a point that I'm going to be affecting the patient's quality of life because of the therapy, which is, for example, the other adverse event, such as hyperglycemia. Usually I support myself with an endocrinology team if I'm having, for example, some trouble controlling the diabetes. And on the other part, it's important to have this two-way communication with them. Are they willing to pay the price of toxicity if I push further with the chemotherapy, or the other way around? If they rather, maintain the quality of life as much as possible, then I would probably limit myself on the number of doses of EB down the line.
Yeah, and the rash is interesting. I actually seen the maculopapular rash. The neuropathy you won't see as a provider, right? You have to ask the patient to tell you. But the rash I've seen, and I've seen that, and it's amazing. I tell the patients, well, that means the drug must be working, and that gives them a little bit of hope, but or reassurance. So moving on, I think we are going to skip this because we already kind of talked about SG and it's not approved anyway. So I'm going to go ahead and skip this slide if that's okay with you. But this one, we haven't really talked much about FGFR inhibitors. But what's your experience do you have any experience with FGFR inhibitors? Do you, especially with their toxicities, what can you say about this class of drugs?
Yeah, I do have some experience using urofetinib, and the toxicities you worry about is mostly hyperphosphatemia and ocular events, especially the central serous retinopathy and the retinal pigment epithelium detachment. So 2 key things. One is going to be the prevention, and the second one is going to be the early detection. So what I do is I always get this baseline ophthalmologic exam and repeat it every 2 to 4 weeks, at least for the first 3 months. That I know it's a lot of visits and I know it's a lot of time, but because of the severity of this type of adverse event that the patient could go blind, I'd rather be more careful in this specific scenario. So what I tell the patient is that they need to report if they start having some blurred vision or metamorphosia. So in those cases, I would hold therapy immediately and refer them to an urgent evaluation. And I have held erdafitinib in patients who are responding because of the ocular toxicity. And most cases important are going to be reversible with drug interruption and with the dose reduction. So if we identify them, and we can restart earlier if we do the, the discontinuation in time.
Yeah, that's a good point. Did you do any proactive mitigation starting any of these therapies, or any preventative measures, for example, for EV toxicity?
Usually I do the supportive medicine for the skin, such as, for example, prophylactic creams, and I do counsel them on the very, basic things they should be doing to avoid, for example, detergents or things that might be irritating their skin. And for example, for hyperphosphatemia, which also is another class effect, I recommend a low phosphate diet from the start. And if it's needed, some phosphate binders earlier within their treatment course, if the phosphate levels start rising above target. So here, patient education is quite critical. And at the end of the day, these type of patients do need a multidisciplinary team. So I think it's an important message that these patients should be referred to a high volume center, ideally.
Good. And I think we talked about this, so you told me the cough was a big one for the pneumonitis. Any red flags to call you about. So I think we'll skip this slide since we kind of already went over it earlier. So okay, so let's switch to gears in segment 5. Segment 5, which is patient education. So advanced urothelial carcinoma, it's a marathon of complex choices. We have surgery, bladder preservation, immunotherapy. Education is a treatment partner because it drives safety, patient adherence, and also quality of life. Let's see, maybe this is actually a very good one for, this talk about surgical counseling. Dr. Dos Reyes or Dr. Nogueira, do you have a playbook on how to help patients decide between, for example, an ileal conduit versus a neobladder? What is it that you tell them for these patients to make a decision?
So basically, but I see, of course, that they have the medical conduct, medical characteristics, tumor characteristics. But if they can choose one. Usually, I explain that the good and the bad, and usually we have sometimes one patient with a new bladder can talk to them, and one patient with a conduit to talk to them in a video that we show the video. But basically, if the patient with a new bladder has to be motivated for catheterization, because new bladder is not forever. And then it's my experience. Even the patients who really do well, and after 10 years, maybe he will require, or even less, he will require catheterization. So it has to be very, very motivated on this. And they have to learn that we will not void by desire, but they will void by clock. So we will have to tell them to go every 2 hours, and they will experience the incontinence. So if they are really, really motivated by body image, they will choose this. But they see that is not, this is not Disneyland. They have many problems in this. They have all the metabolic problems, and then we explain everything to them. The other part, so pre-ileal conduit is more related to the body imaging, works well if they had to travel or go to the beach. Maybe this is something that they can't stand it, so they will prefer the new bladder. But I will explain like the skincare, and I would explain also about it, that when they travel, what they have in the supplies, and all the the stoma team. They comes the team, they join us, they explain where the stoma, change the stoma, and that's it. But basically, to have a new bladder, patient has to be very, very motivated. I have a few cases that I convert a new bladder in a stoma. I believe that all of us, we have this kind of case. So, and this is what I do. Basically, it's the good and the bad for everyone. So the metabolic, the necessity to catheterize, avoiding by clock, not by desiring. The incontinence that's during the day and during the night too. And by the end of the day, the stoma, that's completely changing your body image. We know that there are many published literature show that after 5 years, the quality of life of both are the same. So if you have a ileal conduct, it's pretty the same. People still happy with this. This is what I do. Now, there is another thing also. When you have a patient with a new bladder, you have to scope the bladder. You have to tell them that we need to scope the bladder. That's with the ileal conduct, we don't do this. That's it.
Okay, and then
Sorry.
no problem. I think yeah, most of education. I think I tend to use a lot of pictures when teaching patients about neobladders, for example. But I wanted to discuss this topic for you guys, especially the surgeons. And this is a topic that I sometimes struggle to mention as well for patients that want to do, you're counseling them on a radical cystectomy. But I'll ask, between the three surgeons in the room, who do you guys
Well,
regularly bring up erectile dysfunction?
yes.
When do you guys address it, or do you guys wait for the patients to ask you about that?
So I think it's very important to raise it early. So to normalize early, I think it's very important. You have to talk in a very open way to the patient about the sexual activity. Maybe the first sentence would be, so now we have to talk about sexual activity, and you have to ask him, how's the sexual activity right now? Because that's the basal you will have. And then talk about all of the problems he will have in the future. It obviously depends on what kind of patient, what age, which situation, etc. So there are a bunch of things you have to talk with him, and also with a woman. So woman, I think it is much more easy for us to talk with a man about sexual activity, but it's more difficult with a woman, especially in our countries. But that's also a thing we have to do, and we have to talk, let them know about all of the alternatives they have to maintain sexual activity or to regain sexual activity after the surgery or after the trimodal therapy. Also, that will lead also to some sexual problems. But it's again, especially in young patients, it's very important.
So basically, I do the same with regarding sexual life. For males, it's the same discussion that I have a radical prostatectomy. It's pretty the same discussion, and we have this before. For females, that they can have, we go and say that maybe you have a tight vagina and dryness and experience something. And if we remove the anterior wall, vaginal wall, so we can not have any cessation, and we know this. So you say this. Usually fertility preservation only for young patients, but I can tell you it's quite rare. It's not common to have this kind of patients. We say that for incontinence, that if it's new bladder, we talk about the pelvic floor. But only after surgery we talk about this. We talk about incontinence, and then we see how you are gonna, if you're gonna leak or not. That's what we do.
Yeah. Do you guys do a trimix injections or Viagra, or do you guys just refer those out to the men's health experts? What do you guys do?
I used to deal with this, so we use the tadalafil, daily tadalafil on trimix injections early as possible. And actually, we treat like we treat radical prostatectomy patients. And as was said by Mario and Rodolfo, I think it's an upfront conversation that you have to have with the patient, and they have to deal with his expectations and what are going to face in the future.
Yeah, I think that kind of goes well with the survivorship plan. Do you guys do that, or I guess let me switch it up. Do you guys do any rehab cystectomy education? Do you know, before surgery, do you guys tell them to stick to a diet or see a nutritionist or do this exercise? What do you guys tell the patients as instructions for surgery?
So we do a prehab at our center. We do a nutritional, physical evaluation, and according to that, we schedule a program, usually starting 1 month before the surgery. And regarding survivorship, I think that's something we don't have really. We don't have a survivorship clinic like in the US, for example, in many centers. Um, Usually you have to, as the treater, as a treating physician, you have to look for all of these topics listed here: smoking cessation, exercise, and the visits. So I think that's I think a big need in our setting.
Okay. Good. I think we're down to almost, yeah, online. I know here in America we have, you know, constantly I'm having to compete with Dr. Google, but you know, when a patient asks information, is there a where do you guys direct them? Do you guys send them a specific website, or does your university have online information to direct those patients? What do you guys do?
So we have some information documents that we have they have done, but there are also very good web pages, the Beacon web page or the World Bladder Patient Coalition, which also has a lot of materials, in our case in Spanish, I'm sure also in Portuguese. So I think that's the way to show the patient that the information they have to take serious is this one and not some other thing. And if they come with some other some other kind of information, I always ask the patient to show it to me, and then I will probably tell him with arguments that it's not true.
Okay, well, I think let's see. Yeah, I think we're done. So thank you for joining us. It's been a pleasure, and enjoy the rest of your evening, everybody. Thank you so much.